Welcome to Behind the Scope, Empire Urology Clinical Case Conversations. I'm Dr. Alex Small, Assistant Professor of Urology at Monefiore Medical Center, and I'm joined by my colleagues, Dr. Christopher Anderson and Dr. Gina Badalato, both Associate Professors of Urology at New York Presbyterian Columbia. This podcast, sponsored by the New York section of the AUA, aims to take you through the key clinical decision-making and technical aspects of high-yield urologic cases. We'll present hypothetical cases that highlight experts' differential diagnoses, preparation strategies, treatment recommendations, and thought processes. Each episode will guide you through the step-by-step evaluation and management of specific urological conditions, emphasizing relevant clinical guidelines and featuring a variety of guest experts. So join us as we explore the complexities of urological care and deepen our understanding of clinical practice together.
All right, great. Well, welcome back to another episode of Behind the Scope. Alex, Gina, how are you guys doing?
Doing great. Excited to dig into this interesting topic.
I am Gina. How are you doing?
I'm doing great. Excited to hear from you, Eugene.
Good. Yeah, so we are really lucky today. We have an expert with us to talk about bladder cancer. We have Dr. Eugene Pietzak. He's a urologic oncologist at Memorial Sloan Kettering, who is a specialist in bladder cancer. He's a thought leader. He's an expert, friend of the show, and really happy to have you here today, Gene. Welcome.
Thank you so much. Very excited to be here. Thank you for the invitation. Long-time listener, first-time caller.
Yeah, by the way, I've always wanted to say friend of the show, so thanks for letting me do that.
Definitely a friend of the show. Yeah.
Right. So I'm going to present a case, Eugene, and we're going to kind of talk a little bit about it. And this is a case that you see every single day in your clinic. So this will be very familiar to you. This is a 68-year-old, otherwise healthy, former smoker who presents to your office with a newly diagnosed bladder tumor. He had asymptomatic gross hematuria, which has since resolved, and a CT urogram demonstrated a 3-centimeter bladder mass with no extravesical or upper tract findings. His cytology was negative. So is this a patient that you're familiar with, Eugene?
Yeah, it's someone we see on a daily basis. It's the most common presentation of someone who potentially has bladder cancer with the asymptomatic gross hematuria.
Awesome. And so as you're thinking through this, do you routinely offer these patients an office cysto, a flex cysto, or do you counsel them about going immediately to the operating room?
Yeah, I think it's more of an individualized basis. I think part of my practice is also more referral based. So they'll often have a flexible cystoscopy with their local urologist. And then, almost invariably, either the urologist will refer the patient over to where I'm at Memorial Sloan Kettering, or sometimes, the discussion will come up that it's likely a cancer, and then the patients will self-seek coming to, a dedicated cancer center or an academic center. So oftentimes they already have a flexible cysto. If they have not, I'll at least have that discussion with them. I tend to, especially in new bladder masses, I've been more and more often getting bladder MRIs. We have a radiologist who is particularly interested in MRs. And so we have this combined bladder pelvis assessment that's combined with a MR urogram that's really nice. So if they certainly already have not had cross-sectional imaging, or if it's a larger mass with a higher risk, or their positive cytology, they have a cytology that's positive or suspicious, I will tend to try to get a bladder MRI. And the way that I sort of counsel the patients is it's better to get it before the TURBT, because afterwards there's so much inflammation from the resection. It's really hard to discern whether or not there's invasion present or not. And I sometimes do find that helpful to get if there's a potentially invasive cancer for better staging.
And then for the patients that, how do you, I know you're working in a highly specialized environment where people may have come in with a pathologic diagnosis already, but presuming you're encountering this person for the first time, and may have, offered them a flexible cysto, they declined. How would you counsel somebody about the TURBT, the risks and benefits, the goals of that procedure, assuming they didn't have an MRI prior?
Yeah, so I typically, discuss with the patients, explain obviously that it's an endoscopic procedure. I think a lot of patients are reassured that there are no incisions, and if they haven't already had the cystoscopy and haven't had the experience of, the scope going through the urethra, I'll sort of explain that. I'll emphasize that they're asleep during the procedure because obviously, that's always a cause for concern. And the way that I explain what a TURBT is, I describe it as both diagnostic and potentially therapeutic. We're going in there. The plan is to take a look around, the mass that's identified on the CT scan. I typically kind of give them a warning that it's not uncommon for us to find, other smaller masses as well, some satellite lesions, etc. So I sort of prepare them that like the reason why the cystoscopy may be potentially beneficial is we have a better sense of what we're dealing with that may be underrepresented on the urogram. And I also tend to find, what's seen on the CT scan, the masses are almost always slightly bigger when we're doing the actual resection itself. And so, to have that discussion with them, I'll kind of give them the expectations that most of the symptoms they'll be experiencing will be urinary in nature, urinary urgency, frequency, blood in the urine for, several days. And I typically sort of set expectations that there's a chance they may have to go home with a catheter. No one likes having the catheter. It can be a little bit difficult to deal with. But I kind of use the analogy that the bladder is like a balloon that sort of fills and expands and contracts. And just like the wall of a balloon, as it expands, it thins out. And so if we're going in there, we're scraping or resecting the wall of the bladder, we don't want it to always, it may be unsafe. It continues to expand and thins out further. And I like using that analogy. Because then I talk about after the TURBT, there's a scab that forms on it. And if it's constantly expanding and contracting, the scab could shear off and result in hematuria. So I think sort of preparing them, especially if they have a medium to large size tumor that they may be going home with a catheter, I think is beneficial. And we're very fortunate to have very good nurses. They get, education and teaching from them. So I feel like, you set expectations up front and it minimizes the number of phone calls. And, when the residents and the fellows that we work with, we try to send patients home as well with, peridium if their kidney function's okay, and sometimes oxybutynin, et cetera. And then I try to also, explain up front that narcotic pain medication doesn't help with the pain and discomfort from either the catheter or the TURBT itself, and that extra strength Tylenol may be the best medication for them as an anti-inflammatory. I think setting those expectations up front for what they could expect, and just sort of preparing them that it's typically self-limited and should only hopefully last for a couple of days.
You make some really interesting points, but one of the things that you probably have spent the most time talking about is talking to patients and setting expectations before you even touch them. Because I agree that the more time you spend in clinic having those conversations, the better it is after your procedure, whatever you're recommending for them. It helps them know what to expect. It helps reduce phone calls to the clinic, but it does require some extra effort on the front side, on the front end. And I think it's really valuable to do that. It sounds like you're spending a fair amount of time having these conversations.
Yeah, I mean, Chris, I completely agree with you. I think the more time you spend up front, and this is, I think, probably one of the most common procedures that urologists end up performing. But for the patient in front of you, it's the first time they're dealing with it. As you know, statistically speaking, the vast majority of these are going to end up being cancer. And even if it's a low-grade cancer, it still comes with the connotation of the C word. And so, you kind of want to start to build a rapport with the patient early on and set expectations that, this is going to be treatable. It's just figuring out what it is. And a lot of these patients end up having, say, non-muscle invasive bladder cancer, and it's nice because you could develop a relationship with them because they're coming back in for their their surveillance scopes, etc. So I do like that about the care of patients with bladder cancer for sure.
Yeah. Chris, did you want to jump in regarding anything Eugene just commented on, the use of MRI, the counseling before TURBT, anything that you do differently in your practice?
I mean, I agree 100% with having these conversations up front, especially for the patients who are, this is the first time they're having the procedure done. What do I expect? What exactly are you doing to me? What is it going to feel like afterwards? How do I make, what medicines do I take? These are very common questions that happen every single day. And it is worthwhile having that, 10-minute conversation ahead of time just to kind of help people feel more comfortable heading into the unknown. I mean, some of these patients have never had surgery before. So just kind of helping them understand and allaying some fears. And I think that helps a lot.
Totally. And what you said about encouraging not using narcotics for this particular type of pain and encouraging patients to be aware of that upfront, I think is really important about setting expectations about their recovery also. Thinking a little bit more about the procedure itself, Eugene, do you use blue light cystoscopy? Would you use it in this particular scenario? What is your take on that?
So, we have the blue light, we have the Storz equipment. It's just very rarely do we use it. And that's just really in part because, my personal preference is for the Olympus resectoscope, the bipolar setup. It's just a better scope. I think it's a better quality TURBT compared to at least what we have with the Storz equipment that we have. And I would say in my own personal experience, maybe I did like 50 or so consecutive TURBTs with the blue light setup, and I just didn't really find it that beneficial. And with the Olympus equipment, we use narrowband imaging. And so I think I fully acknowledge that the AUA guidelines suggest that if you have access to blue light, it's recommended that you use it, or at least enhanced cystoscopy techniques. So my preferred approach is narrowband imaging. I think there's definitely data supporting that use of blue light for your TURBT could potentially reduce the risk of early recurrence. But the trial that was conducted in the United Kingdom, the photo trial, basically suggests that that's not really like a long-term benefit, at least in terms of like the first recurrence. So in that particular study, that was a negative study. And I think that study, that randomized trial, does take some criticism, but I actually thought that was a very well-designed and constructed pragmatic study. It's just the Kaplan-Meier curves initially separate in the first 6 to 9 months or so, and then they come back together longer term. So it's the underlying biology, the urothelium itself. I think the most important thing is you're really doing a high-quality TURBT the first time. I think that's probably your best chance of reducing the risk of recurrence. And, I tend to potentially use a slightly wider resection because the way that I at least teach the residents and fellows who work with me is, there's been numerous studies at this point that show, the closer you are to the visible tumor, the more sort of precancerous molecular changes there are. In cancer-associated genes, even though visibly the urologist doesn't see the change, and even histologically, the pathologist may not notice, may look like normal urothelium. Like there are molecular changes that are precancerous, and so I think if you go a little bit wider around the resection and foldrate around the edges, that reduces the risk of what would best be described as local recurrence around the resection site. And so I think this patient certainly would be a candidate for blue light cystoscopy, but it's not something that I routinely do, just narrowband imaging.
That's interesting that you talk about the guidelines and kind of the discordance between, your practice and what the guidelines would suggest, because yes, the guidelines say if you have it, you should use it. Although, correct me if I'm wrong, the studies that really showed the value of blue light were primarily for high grade, CIS high grade recurrences or reducing high grade recurrences. So, if you have someone who you suspect has low grade bladder cancer, should you still be using blue light for them? What are your thoughts on that?
Yeah, the photo trial will definitely suggest that for low grade tumors, there's no benefit necessarily to doing it. But I think a lot of it comes down to sort of the urologist comfort levels with things. And, I'll hear arguments sometimes that people will use blue light on a majority of patients because they have trainees with them. And, it's easier for them to sort of teach what carcinoma in situ looks like, what, sort of the resection is. So I think it is something that's very dependent. I like the idea of using narrow-band imaging though, because it's on the scope, it's easy, it's cheap, it's it's no additional cost. There's no prep, there's no setup, there's no workflow that's needed for it necessarily. And blue light stopped making flexible cystoscopes as well. So with MBI, you could follow them with surveillance as well using the same enhanced cystoscopy technique. So I think you're right, though. Blue light is best utilized for patients with CIS and probably those that have a positive cytology, but a visibly negative white light cystoscopy. And I think it's user dependent.
Eugene, it's Alex here. I'm an endourologist, so I really enjoy the kind of endoscopic surgery aspect of bladder cancer. And certainly some of these larger bladder tumors can get pretty technically challenging. So say you are in the OR, you go in with your Olympus bipolar resectoscope and you identify that this patient has a big 4-centimeter papillary bladder tumor along his back wall. Can you kind of walk us through your approach to actually resect down this tumor? How do you mentioned a high quality TURBT. What are your components of a high quality TURBT?
Yeah, for something this large, I typically, if it's small, if it's less than 2 centimeters, I will try to do more of an in-block resection nowadays. Again, I think there's some data suggest that it could potentially reduce early recurrence, but again, we're not the resection itself locally. I just, the way that I conceptualize it isn't changing the urothelium elsewhere in the bladder, and that's why perioperative chemotherapy, even if you do an in-block resection, is probably beneficial. Anything over 2 and certainly approaching 3 centimeters, I just find it's very challenging to actually remove this specimen in block. And early, I would say in my learning curve with the in block resection, there is a little bit nothing. There's almost nothing more frustrating than you do this nice in block resection and then you essentially have to try to chop it up to remove it. And I know that some people, we'll use encatchment bags and stuff like that, but that's, a little bit too much.
Do you do your end block resection using bipolar TURBT, or have you tried it with laser? I mean, as an endourology guy, I've seen some pretty cool videos online of thulium laser end block resections that have been going around.
Yeah, I sorry to disappoint Alex. I'm not I'm not very fancy with it. So I just use the in-block. I do my in-block technique with the bipolar setup. I have not tried the laser, and I probably will not. I mean, the majority of the cases, at least just the way that I structure my OR experience, I typically do all my TURBTs, all my endo cases on one day. We're there basically from 7:30 in the morning to 6, 7 o'clock at night. And it's just, it's typically all bipolar TURBT for the most part. And so I've been doing it for a little while now and find that it is nice. And one of the pathologists I work very closely with, who's the lead pathologist for the TCGA, Hekman Alamati, he's told me that he does when we do the specimen or when I send the specimens in block because it's, easier for them diagnostically. But for someone in this situation with a 4-centimeter tumor, the way that I would typically approach is just the standard with a standard resection. I tend to use a very, very much a staccato technique, but I will try to debulk initially. So obviously the first thing I'm going to do before I even start resecting is I'm going to do a full panendoscopy, sort of map in my mind the tumor's location, where it is, in reference, obviously, the ureter orifices, et cetera. If identify any other tumors, I'll start with, an initial look around. I will often switch to the 70-degree lens as well, especially for a male, and make sure the anterior bladder neck is cleared. I often find when I'm coming in for restaging TURBT that was initially done on the outside, that's one of the most common locations where we'll find like a small little residual tumor. It's usually anterior towards the bladder neck, particularly in a male. So I'll routinely go to a 70-degree lens. I'll do 30. I'll do the white light and NBI with both the 30 and 70-degree lens. So I feel like it does take a little bit more time, but I feel like I do a much more thorough job in terms of fully assessing the bladder. And again, not to harp too much on the blue light discussion, but I think at least part of the benefit for using an enhanced cystoscopy technique, whether it's blue light or narrowband imaging, is it forces you to take, at least one or two additional looks around. And so, oftentimes you'll hear someone, who does blue light or even NBI, they'll say like, oh, when we looked around with enhanced cystoscopy, we identified this area. And then when we look back on white light, we now see it. And I think it's more, just being more thorough than anything else. So after the panendoscopy, and then it's time to start to approach the tumor itself. And if it's just this solitary 4-centimeter papillary tumor, I will tend to debulk it, so to speak, and send off the first sample as a superficial resection. And then I will do a deeper resection, making sure I'm getting a muscle wall throughout the entire area and sort of at least a centimeter or so margin wider than what the stalk appears to be. And that's because I always think like there can be tentacular growth to the invasive component, and we want to make sure we identify that. And as I sort of alluded to, I use bipolar and I use a staccato technique where it's sort of like a tap, 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 tap. I typically do not use paralysis, although I have partners that routinely will have like LMAs and paralyze their patients if there's like a lateral wall tumor. I tend to find that we could do it even under max sedation essentially, and use a staccato technique and still get good deep resections. Once in a while, someone may need to be converted to general anesthesia, but it's fairly uncommon. And I feel like, I could do a fairly good quality TURBT. The pathologists, I think they really appreciate when you send the deeper section separately, especially for the larger tumors. So they're not like just looking through all these, cassettes looking for the muscle. You're trying to like make their job easier, really.
Now, if you encounter like a small satellite lesion when you're resecting a big tumor like this, will you send that off separately or will you just fulgurate it away? How do you approach those?
Yeah, that's a great question. I try to send everything off separately. If there's a bunch of tumors that are in a cluster, I'll send those all together and I'll sort of designate it as that. But yeah, I do like to try to send off each tumor separately. In this like low grade patient, it's probably less less of a concern or so. But I do find sometimes with patients who have high grade disease, if you send off all the specimens separately, they'll have a better sense of like what their real risk profile is. If they're seeing that there's 4 or 5 separate high grade T1 tumors with additional risk factors that may be associated, that's a much different conversation than, if it's all sent in bulk and, you're trying to describe what you see. So I do actually find that helpful to do.
Yeah. What about immediate post-op chemo? Are you a fan? And if so, what drugs do you use? And who do you think is going to benefit most from them?
Yeah, I definitely would say that I am a fan. I would say for anyone with a new bladder mass that's relatively small, even this patient who has a 4-centimeter bladder mass with a negative cytology, and if it appears to be low grade, I think there's very little harm to doing it. I preferentially use gemcitabine based off the SWOG study. I think that's typically better tolerated than mitomycin. It's less of a vesicant, it's a non-vesicant compared to mitomycin, and there's less concern for contractures, etc. In the randomized trials, it basically shows that there's a potential, decreased risk of recurrence. It's, somewhere around like 15 to 20% or so. It doesn't add any additional side effects. And the way that I explain to patients, it's also dirt cheap. Gemcitabine is like $55. So I'll routinely have it ordered and prepared, have it like possible, intravesical chemotherapy on the consent and sort of just, if they could potentially benefit it, give it. If it's a benign, if it's a papilloma or a pun lump, they may still potentially benefit from it. And if it ends up being a high-grade tumor, then, there's really minimal harm to receiving it. But I think for the most part, the data suggests that it's small solitary tumors benefit the most from it and may not need any additional treatment. But, I still think there's little harm or downside with gemcitabine.
Yeah, that's certainly what we use. I think we switched completely from mitomycin to gemcitabine since the SWOG trial was published. So I think we're very much in line with that. So, all right, so let's get back to our case. So you take this patient to the operating room, you completely resect the solitary 4-centimeter papillary tumor, and you get the pathology back that's consistent with low-grade TA. Now, first of all, the specimen does not have muscle in it. When you are resecting a tumor that you think is low grade, are you always trying to get muscle, or is it okay to not get muscle if you don't think it's invasive?
Yeah, I would, in this particular patient with a 4-centimeter tumor, I would certainly be aiming to get muscle. If it's someone with a known, recurrent low-grade TA history, then no. Actually, I in many ways try not to get muscle in some of those patients just to potentially reduce the risk of scarring, reduce the risk that you will not be able to give intravesical chemotherapy. Even though, again, the data is kind of limited for recurrent low-grade tumors, I still think there's a little harm, so I'll do it. But, also like from a quality of life standpoint, if we could avoid potentially having them go home with a catheter, et cetera, for these people who are recurrently, going through it, the recurrent low grade TAs, especially the multifocal, those are the patients, as Alex sort of alluded to, where, I would probably tend to take more, representative biopsies and samples, and sometimes just cold cup biopsies and then fulgurating if they're really small, and then just fulgurating if they all look identical. None of them are really outliers, and just trying to minimize really the impact of the TURBT on them.
Yeah, I'll agree completely. So you said you have a TURBT day and you're doing, who knows, a dozen or more of these cases in any given week. That's a lot of pathology to review. How are you communicating this to patients? Are you calling patients? Are you scheduling visits with them, video visits? And what techniques have you come up with that you think are helpful when you're delivering this type of information?
First, as we sort of were discussing earlier, a lot of it is also discussion beforehand, right? So before they're scheduled for their TURBT, about setting expectations. But I'll typically try to stop by and at least, obviously discuss with families, but try to talk to patients as well in between cases when they're in their recovery room and sort of explain what I saw, what I think is likely going to, come back as the pathology, and what I think the next steps could potentially be. I have a very, I guess I would describe it as like a very niche type of practice where my research and my clinical practice are very much like aligned, which, since there's residents and fellows listening, took a while to really get to the point where I'm like very satisfied and happy with it. Took, several years to build it that way, but I'm involved with a lot of clinical trials and biospecimen protocols. So I tend to try to discuss the pathology results over the phone with pretty much every one of my patients. So I do my TURBTs typically on Thursdays, and sometimes on my other OR days, Wednesdays and Fridays. And my clinic days are typically Monday, Tuesdays. And so I'll schedule phone calls either before clinic or after clinic. And oftentimes actually when I'm like commuting into the city, because, what else am I going to do during that time? So I'll have discussions with patients typically, before my clinic or after. If there's, patients who have higher risk disease and it's a conversation of, cystectomy, or if it's a complicated sort of BCG unresponsive discussion where we have to lay out the risks and benefits of all the various treatments, then I'll have them come into clinic. But I often find it easier telling them what the pathology is, explaining it, going into a little bit of detail. And then I'll send them to the BCAN website, the Bladder Cancer Advocacy Network website, which I think is very helpful. So it's bcan.org for those not familiar with it. There's a lot of good articles, a lot of good videos, message boards, chat boards. And I find like whenever, especially for new patients, even for low-grade patients, once they hear the C word, the cancer word, it's difficult for them to process the next steps. Certainly for a low-grade patient, you want to sort of set expectations. So like there's less of a shock and they kind of know that it's okay to just, take another look back in 3 months or whatever your plan is going to end up being. But I find like for those, especially for high grade pathology or more complicated conversations, telling them, hitting them with the news, having them do some research on their own on a well sort of carefully vetted resource like Beacon, and then having a follow-up discussion a week later or so helps alleviate a lot of anxiety that they may be having, and has them come in, and it's definitely a more informed discussion for sure.
Yeah, I agree. Beacon's great, and I also refer patients to it. So let's talk about our patient with low-grade TA. So you give him a call, or you bring him into clinic, and you're trying to educate him about his disease. So what exactly are you telling him about the risk of recurrence, the risk of progression? Is this something he needs to be worried about, or is this something that maybe a little bit less aggressive and he can relax a little bit? What are you talking to him about?
Yeah, so I think for this patient with a 4-centimeter tumor that's a low-grade TA, I'm typically counseling this patient that, first off, this isn't a life-threatening situation. The risk of progression is incredibly rare. It's fairly uncommon. The literature would suggest that it could be around like 2% or so. But I think, Chris, as you know, like both Memorial Sloan Kettering and Columbia tried to conduct a research project where we were looking for tumors that went from a low-grade TA to an invasive high-grade tumor. And between our two centers, we just couldn't find enough patients. So it's pretty uncommon. Grade migration certainly happens, and we'll see some patients go from a low-grade TA to a high-grade TA, and often it will be described as, high-grade foci in the background of low-grade, et cetera. Part of that may just be the pathologist who's reviewing it, right? There's definitely variability amongst the pathology reviews. But I will definitely counsel this patient, even if he received perioperative gemcitabine, that he roughly has about a 50% chance of recurrence over the next several years, with the highest risk in the first 2 years or so. Hopefully, and for the most part, like early recurrences shouldn't really hopefully be happening. So I'll typically scope patients 3 months later. And for the most part, because I typically advocate for a wider resection, like local recurrences are fairly uncommon. But it is not uncommon for, 6 to 12 months later, there to be some tumors that develop. And just say for the trainees on the call, oftentimes you'll see that they'll develop sort of at the dome or the anterior wall. And at least there's a lot of speculation that may be because the air bubble, some of the tumor cells get trapped in the air bubble and they sort of implant up there. I have definitely seen that myself in practice, especially for patients who have not received a perioperative chemotherapy for whatever reason. There tends to be a high recurrence rate up there of like small little papillary tumors. So for this particular patient, I would definitely discuss the risk benefits of receiving additional intravesical chemotherapy once a week for 6 weeks. The guidelines also suggest BCG is an option, but we're in the middle of a BCG shortage. And at least, I've been on faculty now for 8 years. We've always been in the BCG shortage. So I've actually never given BCG for a low grade patient. My workflow is typically to offer intravesical gemcitabine again, because I just think that's better tolerated. And that tends to be like my go-to treatment. And if gemcitabine, they have a recurrence after gemcitabine, then like the next line of therapy I'll think about is mitomycin. by the next line. And then very rarely, if I ever have a patient then continue to come back, and it's fairly uncommon. And I should preference that if it comes back after gemcitabine, I also talk to them about what clinical trials we may potentially have open. But if they're then coming back again, then I'll actually try gemdosi in some patients. I have a select few number of patients that I've used that for low-grade tumors. But I kind of like the idea of going from gemcitabine based to mitomycin, and then a gemcitabine based with docetaxel. But that's kind of been my workflow. And I, at least the way that I counsel patients, it's really about their quality of life. So it's the disruption in their, day-to-day activity of coming in once a week for 6 weeks for the treatment versus, the potential risk for having to undergo another anesthetic procedure or more, the cystoscopies themselves.
Right. So and there's the next thing on the horizon here is something that you're familiar with, which is this new drug, the mitomycin gel form that's given into the bladder, is Zosduri, which is now approved for the use of for chemoablation for low-grade bladder cancer. This should be hitting the shelves probably sometime this year, I'm guessing. What are your thoughts on this drug, and how do you think this is going to fit into your treatment pathways?
Yeah, I think, obviously both me and you wrote the editorial for it. So I know we have kind of similar feelings on it. It's it was an interesting pathway to development. It is a chemoablation. It's positioned to try to minimize or reduce the need for TURBT. And, in this particular setting where we already resected the patient, it would not be indicated, right? Because what we're talking about is adjuvant to prevent future recurrences. But if this patient was to have another recurrence, then, the drug is now essentially FDA approved, so would be available. I think, and I'm a little bit reluctant at this point to know where it's going to fit, in part because, I write a lot of grants on bladder cancer, and the opening line I always say is like, it has non-muscle invasive bladder cancer has the highest risk of recurrence, and it's also the most costly cancer to treat. And so the price tag on, the mitomycin, the reverse polymer gel of mitomycin is like roughly $120,000 for the 6 installations from what I saw. And that is, honestly, that may not be sustainable for all these patients with low grade TA to be treated. So, it's hard to say. I think there's probably definitely a role for patients who are certainly medically comorbid. The trial, as you know, Chris, it was a single-arm, non-randomized study. It definitely demonstrated that there is a strong chemoablative effect to it, and that does seem to be durable. So patients could potentially avoid TURBT. It's a little bit unclear because there are other potential management strategies as well for recurrent low-grade tumors. Some people call it active surveillance. It's what's used in the literature. I typically use the phrase, and the way that I talk to patients about it is delayed TURBT. You have recurrent low-grade tumors. They're not life-threatening. We know at some point you will likely need to have them removed, but it does not need to be right now. The natural growth rate for a lot of these low-grade tumors is roughly about 1 millimeter a month or so. At least in my experience, trying to prospectively measure some of them in an objective manner. And we know that some new tumors will emerge and appear over time. And, the concept of just following with surveillance cystos and monitoring them to watch them grow, that obviously has an impact on patients' quality of life as well, having to come in for the cystos. So you have to find that balance. So I will sometimes see a patient, identify recurrent low-grade tumors, and say, all right, let's schedule, rather than doing another office cysto in, 4 to 6 months or whatever it may be, let's schedule a TURBT at that point. And, if hematuria develops, certainly let us know, but that is pretty rare for that to happen. And then you go in, you sort of clean them out and try to minimize the number of operative procedures they're having. And as you know very well, Chris, because I know that you do this as well, is like a lot of these tumors are very small and you can just foldrate in the office. And that's a very good management strategy if it's, one or two small tumors. In the clinical trial that led to the FDA approval of this, there were some questionnaires that suggested, I think, more than 90% of the patients who were enrolled would not have been a candidate for office fulguration. However, the vast majority of the patients were enrolled outside of the United States. So I honestly don't know their capabilities to do office fulgurations. I think certainly in my practice, the nurses that are helping in the room are very used to us setting up for the fulgurations, and it literally takes 2 to 3 minutes to go from all right, we're doing our surveillance cysto to now we're going to fulgurate these small recurrent tumors. It's very quick and easy. I think in sort of the real world type practices, and certainly in non-US practices, that may be not realistic, and it may be something that certainly in other countries may require patients going to the OR for. So again, it's hard to know. I'd be curious though to hear how you guys are thinking about integrating it up in Columbia.
I also don't know. I mean, we haven't actually used it yet, but it's very tempting to want to use it as an adjuvant therapy, thinking that maybe it would be more effective than an aqueous intravesical chemotherapy that lasts longer, more contact with the urothelium, maybe would be more effective at preventing recurrences. And I think there's a lot of patients who are probably going to be interested in that concept rather than leave my tumor in and see if you can ablate it with this chemo gel. Of course, if someone's not eligible for surgery, different story. But there's a lot more patients who have low-grade cancer who are eligible for surgery, who are getting them removed, who are then getting adjuvant therapy. So I wonder if it's going to creep into that space one way or the other. But we'll find out.
I was just going to say, yeah, I think that's a great point. But as we're beginning to experience with these newer BCG unresponsive treatments that are very expensive, the dealing with the pharmacy and getting, the financial clearances and stuff, I would certainly be very concerned or at least initially, very careful in terms of trying to give it adjuvantly if that's not what it's FDA indicated for, because it does seem to be very expensive. And, as you know, even aqueous mitomycin, there's studies showing that it also has a chemoablative effect. And so, I don't know. I guess it's a really exciting time though, that there are all these novel treatments that do need, further comparator assessment, really.
Speaking of exciting, Eugene, we're going to bring this conversation down a couple of dials, and we are going to introduce a new segment, hopefully that doesn't insult your intelligence, called Things I Always Was Too Afraid to Ask My Attending About When I Was a Resident. This is going to be rapid fire, very basic questions that we're going to ask you to respond to quickly. And so are you ready for this?
Sure, yeah.
How can you tell a tumor is low grade just by looking at it? So what are some features that you think, or can you?
Yeah, I mean, generally for the most part, some of them are quite obvious. Other times it's harder to tell. So generally for low grade tumors, the stalk will be thinner. So that's the first thing you look at. And the truth of the matter is you also look at the patient's prior history, right? So if they had a history of low-grade tumors, they're likely having recurrent low-grade tumors.
That's cheating, Eugene. That's cheating. You can't answer it that way, okay?
Yeah, so you know the patient's history. Yeah.
You don't know the patient's history.
Yeah, and so generally they'll look more like CNMEs with a papillary formation, where high-grade tumors, if they're non-invasive but high-grade, they'll have more like a mulberry appearance, which I had to look up when I first heard that expression, and they look like blackberries essentially. And obviously not sessile, not nodular. So
okay. Speaking of endoscopic identification, so how can you tell if something is CIS versus inflammation? Is this something inflammatory, a Hunter's ulcer, even sometimes squamous metaplasia? Can you is there any primers you can give the audience and what to look out for that?
Yeah, I think that is certainly the furthest thing from a dumb question. It's very challenging sometimes to tell the difference between CIS and inflammation. And I think, a major unmet need is potentially, urinary biomarkers that could help sort of tease that out a little bit more. Certainly what we talked about with enhanced cystoscopy with either blue light or NBI, but there could still be false positives. Sometimes you could see certainly over with NBI, for example, you could kind of see some of the nuclei of the cells. I find, or I think that I could kind of see. But sometimes you just have to do a biopsy, and that is potentially a role for office biopsies if I'm uncertain. And then sometimes you're also dependent upon the urinary cytology as well. So if there's an area that I'm uncertain, I don't want to take the patient, immediately to the OR. I'll send a second cytology, and I'll sort of do a barbotage at the time of the office cysto, like right by where the lesion is, with the hope to, sort of collect some of those cells. But it definitely can be very challenging to tell the difference. But I'm very dependent upon narrowband imaging to sometimes tell the difference in the cytology.
How about this one? How about how long should you keep monitoring a patient's bladder after having been treated for low-grade bladder cancer?
So that is a great question. I tend to have discussions I tend to follow more of the European guidelines. So I'll scope patients with low-risk bladder cancer at 3 months after their TURBT, then 9 months, then 12 months. And if they've been clear for about 2 to 3 years, I'll start to introduce the idea of discontinuing cystos within the next couple years or so. And some patients are very happy to stop doing them. Other patients, sometimes you need to space them out to, every 18 months or 24 months before they're comfortable fully stopping. But I think guidelines across the globe vary, and I think the UK guidelines are essentially to stop after almost 1 year. But I have definitely inherited some patients from my partners who have low-grade tumors, and they're following 15, 20 years later, and they don't want to stop doing their cystos. And it's again, I think maybe there's a role for urinary biomarkers in the future to help with that. But what has your practice been, Chris?
Yeah, I agree. I mean, I'd say if you've hit 10 years and you're still coming back, you should not come back anymore, and arguably much sooner than that. I mean, to your point. But I don't know if there's any firm cut point. And there's definitely patients who love coming in and, confirming that their bladder is clear, and they love you telling them that, and that makes them feel very safe and reassured. So I get that as well.
Do you use any urinary biomarkers now?
Not at this point in time, but we're in the process of beginning some prospective trials and prospective efforts to better study it. So I think with the newer technology and sort of I would say renewed interest or an increased interest in clinical trials in the bladder cancer space, I think there's going to be an explosion of work in the urinary biomarker space.
Well, speaking of knowing when to stop, I think we're kind of reaching the end of our time here. And I just want to pull us out of the weeds to wrap things up and ask you, to kind of just zoom out and think about your training and your trainees that you're teaching about bladder cancer now. And can you give us any sort of final words of wisdom or real key takeaways for the management of low-grade non-muscle invasive bladder cancer?
Yeah, I think with regards to low-grade disease, I think setting expectations and just, making sure that patients understand this is not a life-threatening condition, and it's really about their quality of life. And I think providing options and not necessarily assuming, it's a one-size-fits-all approach. It typically can be very individualized. And, if the patient has a very positive trajectory and very minimal recurrences and they're doing well, they could be managed just in the office. But it can be a more problematic disease for some people with frequent recurrences. And so even though you want to set the expectations that it's not life-threatening, you also don't want to diminish what some patients are experiencing going through. And it's really just trying to minimize the negative impact on their quality of life as much as you possibly can, and finding that balance between doing too much and too little. And I think it all comes down to the patient in front of you and what they want and their comorbidities, et cetera, and all that, and what they're looking for, really.
Great. Well, thanks so much.
All right. Well, I think that brings the podcast to a close. Another great episode. Eugene, thank you so much for being here. We appreciate your insights and your expertise. And I think this is a really valuable overview of non-muscle invasive bladder cancer.
Thank you, guys. I'm very, very appreciative for the invitation. This was a lot of fun. Looking forward to hearing all the additional episodes of the podcast. Amazing, great initiative for sure.
Thank you for joining us on this episode of Behind the Scope Empire Urology Clinical Case Conversations. We hope our discussion enhanced your understanding of the clinical decision-making process of this high-yield topic in urology. Please subscribe to our podcast and check out other episodes on the Empire YouTube channel.